My name is Caroline Ziegler. I am a speech-language pathologist at the Froedtert Medical College of Wisconsin in Milwaukee, Wisconsin. And today I am going to be presenting a short presentation about spasmodic dysphonia, vocal tremor, as well as muscle tension dysphonia, and how voice therapy and a speech language pathologist's role relates to all of those disorders. So for reference, I have no financial or non-financial disclosures for this presentation. I wanted to start out with a little bit of background about everything just to make sure that we're all on the same page as we begin. So starting out, I wanted to first touch on spasmodic dysphonia. I know that's the reason why a lot of people are listening to this lecture today, but just for background's sake, spasmodic dysphonia is an idiopathic focal dystonia of the larynx, so it specifically impacts the larynx, and it's characterized by the uncontrollable and irregular spasms while the muscles are working during phonation. So that includes the muscles that both bring the vocal folds together or close them, as well as open them. And people can have problems with breaks when they are talking. So this is a very task-specific dystonia, which means that when people are not talking, they really shouldn't be noticing problems with those spasms. But when people do start to talk, then they can start to have those problems. And people can have problems with just the adductor muscles having the spasms. They could have problems with just the abductor muscles having the spasms, or sometimes people can have both at the same time. We call that mixed. The next voice disorder that I'd like to discuss is vocal tremor. So vocal tremor is something that can actually be misdiagnosed as spasmodic dysphonia in some people. There's definitely overlap, and there are plenty of people who have both vocal tremor and spasmodic dysphonia. But vocal tremor is its own disorder, and it involves hyperkinetic movement. And in the case of a laryngeal tremor that causes the voice to tremor, it's considered a central tremor because it happens in the midline of the body, as opposed to a peripheral tremor, which is something that can happen more on the extremities. So like your hands, your arms, those sorts of things. And in the case of the cause of a vocal tremor, there's not a single muscle group that's oscillating or moving back and forth. It actually can happen with a number of different muscles in the phonatory apparatus. So basically all the muscles that are involved with people producing voice, and they don't all oscillate in synchronicity. They don't do the same thing at the same time, which can be more problematic depending on how significant that tremor is in those muscles. At least, half of the people who have a laryngeal tremor also have other sorts of tremors going on. So they could have tremors in other upper extremities, including things like their jaw or their head. Sometimes they have tremors in their palate. So if you open your mouth and say, ah, and you look in the way back and you can see the back of the mouth tremoring. Sometimes people also have tremors in their hands or their arms as well. So it's not always isolated to the phonatory apparatus in here. It can be other locations. And one of the things that's very characteristic of tremor is that it's very cyclical in sounding. So there's a rhythmic cycle of that tremor that occurs every 4 to 6 hertz. And so that presents with a pretty characteristic sound. If you kind of think of like that Katharine Hepburn sort of voice, where the voice seems to kind of be bobbing along. Or, in a case of, if somebody doesn't have tremor, you can kind of mimic that in a way by, if you think about if you're trying to talk while driving over a bumpy road, your whole body is moving up and down, and that causes the sound of that unstable voice. Now, in the case of tremor, people have tremor really all the time, and it doesn't just have to be occurring when people are talking. So people can have tremor when they're at rest. You obviously don't notice vocal tremor at rest because you're not making any noise, but if people have tremor in other locations, like say their head or their jaw, you might notice like a slight shaking even at rest. And tremor symptoms do tend to be worsened by things like anxiety or fatigue, or even heightened emotions like excitement. It's a positive emotion, but sometimes that can also make the tremor worse. And the last point about tremor is that more men than women tend to be diagnosed with tremor. Our last voice disorder that we're going to be talking about today is muscle tension dysphonia. So muscle tension dysphonia is a really kind of broad disorder because it impacts a lot of people for a lot of different reasons. The very basic idea of muscle tension dysphonia is that it's an abnormal sounding voice, and that's due to the loss of normal muscle coordination or just improper muscle coordination. And sometimes that's not very obvious unless you're listening to somebody talk, but sometimes it can be very obvious. You can actually see people physically straining. So you can see, their muscles in their neck might stand out or their jaw might look really tight. And you can see that people are using a lot more muscle effort to talk. Now, like I mentioned before with vocal tremor, where certain things like heightened emotions, anxiety, stress, those sorts of things can make tremor worse. Muscle tension dysphonia oftentimes also relates to things like stress, anxiety, even depression. And frankly, a lot of people who end up diagnosed with muscle tension dysphonia do report that they have very high vocal demands. So basically, they have to use their voice a lot. And that could be because of the work that they do. So, an example of that would be a school teacher, somebody who has to talk all day to larger groups of people, not always in the most ideal sound environment. And, there might be other things grabbing for their attention and all of those sorts of things that make it much harder for them to talk all day. But it could also be somebody who, naturally likes to talk a lot and has a lot of people to talk to. So sometimes we see that in people who have like big families and they're always talking to their kids or their siblings or their cousins or their parents. And that's, part of their daily life and who they are. And that's not a bad thing, but sometimes it can cause some problems. Now, with muscle tension dysphonia, as I said, it's kind of a really big disorder in that a lot of people can have it. It's not specifically because of some sort of neurologic or anatomic reason necessarily. So unlike tremor and unlike spasmodic dysphonia, which at this point we are pretty sure are all very neurogenic disorders, between the brain and the muscles. Muscle tension dysphonia is thought to be different than that. And it can occur primarily, so it can be the only problem that people have, but it also can be a secondary problem. So it can occur in addition to other voice problems. So for example, somebody could have a benign lesion on their vocal fold. And because they have that lesion on the vocal fold, they have to work harder to get their vocal folds to come together and then vibrate normally. And that extra work turns into muscle tension dysphonia. That would be a secondary presentation of muscle tension dysphonia. And like I said, because it's such a big disorder, it doesn't always sound the same. So that's part of what makes it kind of confusing for people to know, like, do I have this problem or do I not have this problem. Some people with muscle tension dysphonia have breaks in their speech, like people with spasmodic dysphonia might have. Some people have kind of irregular sorts of qualities to their voice, and it almost sounds like they have a tremor. But sometimes people sound like they're just very strained, and sometimes they sound breathy, like, ah, that's more of a breathy sort of voice. Sometimes their voice sounds a little bit more rough, like, ah, or something like that. And sometimes their voice sounds fine at one moment in a conversation, and sometimes it starts to sound totally different as they're going along, or vice versa. Maybe it starts out sounding not awesome, and then it gets better as they talk. It can be very different from person to person, and even within the same person, people with muscle tension dysphonia don't always sound consistent from one moment to the next. So in general, muscle tension dysphonia can be a very big and sometimes kind of a confusing disorder to parse out depending on the person. So, like I hinted at before, it is also possible to have more than one voice disorder at the same time. So on the right, I have a little Venn diagram just showing that you could have overlap. You could have overlap between spasmodic dysphonia and vocal tremor, or muscle tension dysphonia and vocal tremor, or frankly, you could have all three at the same time. You could have spasmodic dysphonia, you could have vocal tremor, you could have muscle tension dysphonia, and they could all be co-occurring. On the left, I have more of like a spectrum sort of diagrams, so that you could have different presentations of those sorts of disorders. In the red triangle, you see somebody who has a fair amount of both spasmodic dysphonia and vocal tremor, and a moderate amount of muscle tension dysphonia. But the green triangle, you can see that somebody could have a lot of muscle tension dysphonia with just a smaller amount of spasmodic dysphonia and vocal tremor. So different people might look different on those profiles, but it is possible for people to have all disorders at the same time in some varying degree. The other side of this is that sometimes things kind of are on a spectrum in and of itself. You could have a certain kind of spasmodic dysphonia that seems and acts a little bit more like muscle tension dysphonia, as opposed to a very traditional sounding spasmodic dysphonia, which gets kind of confusing for everybody. But that's why we have the sorts of treatment tools that we do. And that actually leads me into my next slide. With regards to treatment, I'm going to touch briefly on what the physician roles are for treatment, just because I'm not a physician, and I know that there are going to be other presentations with other information that's more specific to what the physicians are able to do. With regards to muscle tension dysphonia, typically the muscle tension dysphonia itself is not something that physicians treat, but they will treat some of the underlying issues that may be contributing to the muscle tension dysphonia. For example, if somebody has like a benign vocal fold lesion, like I mentioned before, that is something that potentially the physician can treat. And then by treating that underlying lesion, that can make it easier for the speech pathologist to help the patient treat the muscle tension dysphonia. With regards to vocal tremor, there are a number of different options for people, and some of them fall within the realm of what laryngologists do. Some of them fall more within the realm of what neurologists do. So there are different sorts of medications that can be used to treat tremor. I've listed a number of them here. One of the ones that comes up a fair amount in my practice is people mentioning primidone, but there are other options. With regards to a lot of the medications in that first list, the pharmacological management, a lot of times those things tend to work better for people who have peripheral tremors versus the more central tremors like laryngeal tremor. So while it's not necessarily a bad thing for people to try these sorts of offerings, statistically speaking, more people with peripheral tremors tend to get the benefit as opposed to the central tremors. There are injectable medications that can be used to treat tremor, and the big one is Botox or botulinum toxin, and that usually falls within the realm of a laryngologist's practice. And then for people with potentially very severe tremors, or potentially they have other sorts of issues alongside of the tremor, deep brain stimulation is an option. It's not the first option that people always go for, and frankly, I have only seen a very small handful of people who've had deep brain stimulation and have had also a vocal tremor. So it's not the typical sort of treatment, but it is out there, so I mention it. With regards to spasmodic dysphonia, there are surgical options, and then there's the botulinum toxin option. And with regards to spasmodic dysphonia treatment in particular, that Botox is injected directly into the laryngeal muscles that are spasming during connected speech. So the Botox will work by temporarily blocking the release of the acetylcholine at the neuromuscular junction, which basically makes the muscles weaker and means that they can't spasm when people are trying to use them to talk. And the nerve endings do gradually recover over the course of months. The typical amount of months that recovery takes is about 3, but it's different for people. It's different for doses. So it's always something that people are working on with their doctors to try and figure out what's the best dose, what's the best timing, what's the best location, all of those sorts of issues. Now, with regards to voice therapy and how a speech language pathologist like myself would work on any of these disorders, I want to start with muscle tension dysphonia because that is definitely something that is within our wheelhouse. You know, we really love to treat muscle tension dysphonia, and that's why voice therapy gets an exclamation point there. There are a number of different techniques that a speech language pathologist can use to treat muscle tension dysphonia, and they range from things like using manual therapy, things like myofascial release, circumlaryngeal massage, other sorts of manual techniques where there's actual use of pressure from the speech language pathologist on certain areas to try and get the muscles and the parts of the body that are involved in speech production to work in a more normal and comfortable manner. So if we're going to specifically talk about things like circumlaryngeal massage, in that case, we would find where the larynx is. So I can feel my larynx right here. And we would do gentle massage and manipulation around the larynx, trying to both relax some of those muscles as well as manipulate very carefully, because it's a delicate area of the body, manipulate that part of the body, the larynx, into a very comfortable and relaxed, or at least more relaxed position. A lot of times with muscle tension dysphonia, what we find is that the muscles get so overworked and they get so tight that the larynx actually is elevated into a higher position than normal. And because it's elevated, things are not able to work correctly and things are more uncomfortable for patients. I can palpate my larynx relatively easily, but there are some people where the first time I might do this sort of manipulation, they feel a significant amount of pain because those muscles are so tight and so sore. And just like if you're getting a massage in any other part of your body, like your shoulders or your back or your legs, and you have tight muscles, they can be very sore. So you can have very tight muscles in your neck as well. Manual therapy, involving things like myofascial release, can also be beneficial because sometimes it's not just the larynx or just the neck that is involved in some of that improper usage and increased muscle activation. There are definitely people that I have worked with where they have significant amounts of tension all the way around the neck, even into the shoulders, the upper chest, and how they breathe. So going down to the rib cage and the diaphragm, and all of those sorts of muscles play really big roles in how people are able to produce clear, comfortable voice. And this can be a really big role with muscle tension dysphonia treatment. Some of the other techniques that we'll use for muscle tension dysphonia include using biofeedbacks. So, when people are in the midst of having a problem with their voice, sometimes they don't know exactly what it is that they're doing. So being able to use things as simple as a mirror to be able to take in what your body does as you are talking can be very useful. And people can make a lot of changes just based on what they're able to see and how they're able to make adjustments based on that. And then we also really like to emphasize the use of things like forward focus of resonance, which is an idea that's covered in resonant voice therapy. And with that, it's meant to be a very effortless and efficient way of producing voice. So depending on the person, sometimes we can dive right into, basically conversational voice, but sometimes we have to work our way up from simple sounds like to things like and just trying to regain that sense of what is easy and what is hard, and what is buzzy, as we like to say, feeling a lot of vibration sensation in the front of your face, and what feels very throaty. Now, with regards to vocal tremor, I put a question mark with by voice therapy because it's kind of like voice therapy. Yes, we definitely can do voice therapy for vocal tremor. That said, voice therapy for vocal tremor is usually meant to try and make the tremor less noticeable and to try and treat any compensation strategies that people have developed to deal with their tremor rather than treating the tremor itself. So voice therapy is not something that is going to make the tremor go away. It is not something that is going to fix the tremor at its source. It is something that can make tremor more manageable for people. And that is one of the things that we always emphasize with our patients at the outset, that we're not going to cure the tremor, but we may be able to help you deal with it in an easier way. And there are definitely some people with vocal tremor that are very good therapy candidates, basically people that we feel like could make a lot of progress with voice therapy. And there are some people with vocal tremor that maybe voice therapy isn't quite as appropriate. Maybe the tremor is so intense and so severe that it's very hard to do anything else with it behaviorally. And in those cases, that's why I have that question mark by voice therapy. It's maybe not the best line of treatment for them. It's not necessarily going to hurt anything, but it might be very frustrating for both the patient and the clinician. With regards to treating vocal tremor in voice therapy, we usually like to emphasize things like easy onsets, and that means trying to start your voice with a softer approach rather than a hard approach. We don't want people to be really pushing a lot, kind of going back to what I talked about with the muscle tension dysphonia, because that's one of those compensation strategies that can ultimately mean that it's harder for people to deal with their tremor, even though the compensation is meant to try and make it easier. We also tend to work a lot with resonant voice therapy. One of the things that people with tremor will sometimes do is they'll try and talk softer to try and disguise the fact that they have tremor. And that usually is counterproductive, because then whoever it is that they're talking to can't hear them, and then they have to repeat themselves, and they might get more frustrated by that. And as I mentioned before, things like stress and anxiety can make tremor worse, so it becomes a bit of a vicious cycle. If we can find a way to talk in a more focused and easy, effortless manner, people usually end up being able to be heard better, which means they don't have to repeat themselves as much, and people understand them better, which makes them less frustrated overall. Sometimes one of the other things that we'll work on with vocal tremor is just using the appropriate breathing patterns. I talked about volume, but breathing in and of itself is the power behind anybody's voice. And sometimes with tremor, in order to control it, we find that people breath hold a lot. So they take in a breath and then they try and talk like this. And again, that can be very counterproductive because that adds a lot of tension and strain all throughout the neck and the upper chest. And that's something that we can address in therapy. We can address how do we take in that breath and then use it in a way that doesn't involve adding on a lot of muscle tension. Similarly, for spasmodic dysphonia, I have a question mark by voice therapy, not because it's a bad thing, but just because there are certain things that speech therapy can be very good for with spasmodic dysphonia and certain things that it's less good for. So one of the big things that voice therapy can be very good for with spasmodic dysphonia is helping to reduce just overall laryngeal tension if there is a lot of kind of overlay or compensation with more muscle tension because of the spasmodic dysphonia. And this also, voice therapy can be helpful for separating out how much of the problem is the spasmodic dysphonia itself, the actual spasms, and how much of the problem is just extra compensation to deal with all of those spasms when speaking. And so a lot of what we end up doing with therapy looks very similar to some of the things that I've talked about with vocal tremor and with muscle tension dysphonia. We use things like manual therapy, easy onset of voicing, resonant therapy, making sure breathing patterns are appropriate, all of those things, because they work for spasmodic dysphonia as well in a very similar way that they might work for tremor. Now, with regards to appropriate speech breathing patterns, one of the things that I have seen in the past with some of my spasmodic dysphonia patients is that sometimes, they might not have spasms or tremor in other parts of their body, but because they're so used to having some sort of spasm in their throat, they also start doing different things with their breathing. So one patient in particular I'm thinking of, when I had her try and exhale gently and go, she ended up going and was doing short little exhales every time she was breathing out because that was what she was used to doing with speech. And that's not usually the most effortless way of getting your voice supported by your breath, and it's certainly not the most effortless way of breathing out. So that was definitely something that we targeted in our therapy sessions. And even just making that fundamental change can make a really big difference in her overall voice quality. The last point I have on here with spasmodic dysphonia therapy is that sometimes changing your pitch, changing your inflection, that can be really beneficial. It's not always something that's feasible depending on what sort of pitch or inflection people are starting from. But if people are very strained and they're used to talking also in that lower sort of register, it might actually be worthwhile to try and explore, can we raise the pitch a little bit and still keep it sounding and feeling pretty natural? One of the things I always emphasize with my patients is that if you don't like the sound of the pitch of your voice as we're doing things, you're not going to like it when you're out in the real world either. So you're probably not going to use that voice. We need to find something that feels and sounds more like you. And if you like it, that's great. If you don't like it, then we need to keep on searching for that. But if your voice is, in that low sort of fry place. That's probably not the most ideal voice, and we can maybe do with exploring things a little bit more. Now, with all of those things that I just talked about, the sorts of things that we do in terms of exercises and approaches for therapy, therapy in and of itself is a process. And I wanted to talk just a little bit about that because it is a two-sided process. It's a process that involves both the patient and the clinician. And on the patient side of things, it involves doing things like taking responsibility for the therapy and making sure that you actually have set aside the time to practice things, and you're really committing to that process of making changes with what you're doing with your voice. And sometimes that can be a really scary process. It's certainly not something that everybody is ready for at the exact same time. And we understand that. At least I hope we understand that. And that's one of the things that when we're talking with people about therapy, we're trying to get a sense of, like, is this something that you feel like you're ready for? Is this something that that you have the time for? Sometimes people are very motivated to do therapy, but they also have a lot of other things going on in their life. And sometimes they're planned things and sometimes they're unplanned things. But, therapy is a process, like I said, and it does take time and commitment. And, you're only going to get what you put into the therapy. Kind of like, when you went to school and you did homework and all those sorts of things. Like if you put some effort into the homework and the studying, you got different results than if you didn't. So same idea with therapy. The last point on this slide, though, the acceptance of current abilities, that's part of what makes therapy kind of scary. And maybe not scary, but just it can be emotional. It can be a real ride for some people because you're really facing yourself, and that's not always something that people want to or have tried facing. And sometimes it can be really exciting. Sometimes we find that, hey, I can do more than what I thought I could, or I actually have some power over certain things. And that's really awesome. That's so exciting. And I love experiencing that with people. But sometimes it can be very frustrating. And as much as I enjoy those highs with patients, sometimes the lows are pretty low. And, as I said, this is part of what can make it kind of scary. So all of that is to say, we really want people to know that when you're starting out a voice therapy process, it is something that you do need to be invested in, and it's not just a passive sort of thing. Likewise, on the clinician side, we need to be invested too. We need to know what's going on. We need to know what sort of things we need to listen for when people are doing exercises, and what sort of things we need to watch for as they're doing exercises. And we need to know, when are people ready to start trying different sorts of things with the exercises? When are they ready to maybe move on to a different level or try things with less feedback from us and more feedback from themselves? As I said, therapy can be a scary process, so we really need to know, we need to know what's going on with our patients. We need to be able to empathize and have a lot of compassion. It's a very emotional process sometimes, and being able to really listen and motivate people through those lower times it's incredibly important. And honestly, if you are not feeling like you have that sort of bond with your voice therapist, that can be a factor in how things go with therapy. And I say that because I have heard that from patients before, where, they say that they've tried voice therapy before and they just feel like they were repeating exercises off of a worksheet and it just didn't go well and they were very frustrated. You need to be able to have that sort of relationship with your patients that, you know what sort of things they need to work on, and what sort of things make them more vulnerable or what sort of things really motivate them. So Therapy is a two-way process, and it definitely involves skills on both the patient and the clinician side of things. So these are my resources for this. The Sapienza and Ruddy book is actually a very wonderful voice disorders textbook, and it includes a number of references within that textbook. So if you ever want to look up a good book about just voice in general, I would highly recommend that one. And that concludes my presentation about voice therapy for things like muscle tension dysphonia, vocal tremor, and spasmodic dysphonia. I hope you were able to get at least a little bit of information out of that, and best of luck to you in anything that you choose to do in the future.